20 just with room now. This is our second day of doing the faculty recap, our second year of doing this. And basically, this is a review of what happened at the meeting today. We're getting together at our favorite local pub called Zoom, and we're allowed to have drinks if we want to. You can do the same. We want to give you our honest impression of what we thought was good today and get a little discussion going about that. I'd like to introduce to you, this is the room now faculty who do a stellar job of covering this meeting, both in tweets, writing articles, videos, podcasts, and then doing these recap panels. So I'll begin. I'm Jack Cush in Dallas, Texas. Robert.
Hi, I'm Robert Chao over in Fairfax, Virginia.
Janet.
Janet Pope, London, Ontario, Canada.
Sheila.
Hi, I'm Sheila Reyes, joining virtually from the Philippines.
Yus.
Hi, I'm Yusof from Leeds, United Kingdom.
Antoni.
Hello, I'm Antoni Chan from London, United Kingdom.
And Cassy.
Hi, I'm Cassy Sims from Durham, North Carolina.
Akhil.
Hi, I'm Akhil from Palo Alto, California.
And last but the most, Bella Mehta.
Hi, I'm Bella Mehta from New York.
Excellent. All right, so we're going to begin, and these are things that would have been presented today. Let's begin with Bella.
So hi, everyone. I think this in-person meeting has been exciting after 2 years. The abstract that I found was interesting is abstract number 1579, the TICOG study, which is tight control of gout. It's an RCT of targeted versus conventional treatment for gout. So the conventional treatment is you let the patients be seen whenever they want, and then go do the uric acid lowering therapy. They start at 100 of allopurinol, and then go up as per the uric acid levels. Whereas in the targeted group, they do this every month, and at 12 months they saw results, and they saw that 90% patients in the tight control arm reached the target uric acid level, versus only 40% in the conventional treatment arm reached the target uric acid level, which is less than 6 as per the ACR guidelines. This was non-blinded though, but I think what it shows that the way we are managing gout is not adequate. Using new strategies to come up with treat to target approach even in gout, and trying to make sure that everybody implements it is important. So with that, I think we need to focus on gout patients a little more.
So Bella, first off, the group that was not the tight control group gets a number that is often quoted. Rheumatologists only achieve tight control doing what they usually do about 30–40% of the time, even though you're the experts at gout. So this is very telltale. But in doing tight control and pushing that group to 90%, did they have more attacks? Did they induce more gout flares?
They don't talk about flares as much in the talk, but I think they were also given NSAIDs, colchicine, and steroids, right? So for those, I think the target was like at the end of 1 year, what uric acid levels do you come to?
Okay, so they may have, if they'd done a lot of assessment in between, they may not have liked the story so much. And unfortunately, on your way to tight control, it gets a little rocky.
I guess they were still monitoring every month, which is not possible in the current system, right? You're not going to see a gout patient every month until they receive. So, just given virtual therapies or some, like a mid-level person going in and just titrating that will also achieve something better, I feel like.
What country was this?
This is US.
Okay. Anybody actually do serious tight control in gout in their clinics? I know we all think we do.
We try to.
Yeah, the truth may hurt if we actually knew.
I just try to control the amount of beer.
Yeah, although I don't know if that works either. So
that is true. Touche.
and especially here at the pub, discussing abstracts, I honestly, if you want to be truly tight control, we need to bring back, and you all are way too young. Even Janet, I think, is too young for this. Gout, not the gout. I'm sorry, a gold nurse. We used to have gold nurses, which would run our gold clinics, and they had protocols and they saw patients. There's a lot of literature about gout run clinics run by nurses, way more
Way better.
successful than you would be in your practice, even though you're the gout expert.
That's true. I mean, I think it's about paying attention. I mean, they also did like ultrasounds on these patients and saw like objective changes in like ultrasound measures, double contour and whatnot. So,
Okay, interesting. Akhil, why don't you give us yours?
Yeah, it's actually there are two posters at the Ignite talk, which I'll talk briefly about, but both talk about in light of detection of sacroiliitis in imaging. So one of them was abstract 1255, which was do rheumatologists overcall sacroiliitis imaging in ACSPA? And essentially they looked at the detection of sacroiliitis in central readers, expert readers versus community rheumatologists as well as academic rheumatologists. Essentially they found that when comparing diagnosis of sacroiliitis in central readers versus local readers, there was about 87% agreement in x-rays and then about 75% agreement on MRIs. But when you're comparing the diagnosis of sacroiliitis between academic versus community, there's a greater agreement with the academic rheumatologist versus the community rheumatologist when compared to the central readers when diagnosis of sacroiliitis. And I thought that was just really interesting because there seems to be some discrepancy in the diagnosis of sacroiliitis when using the modified New York criteria, when you have central readers versus local readers, and then this discrepancy between the academic versus community. And then abstract 383 looked at the performance of an AI algorithm in diagnosis of sacroiliitis and looked to see whether there's any agreement with if there's agreement with central readers in the diagnosis of sacroiliitis. And they found that their sensitivity was about 82%, specificity 81, with an agreement between the central readers and the algorithm was about 82%. So which I thought was interesting is that while the it is high, it's still not quite there yet in terms of being something that we can use to diagnose sacroiliitis. Using an AI algorithm as a standard in terms of diagnosis of sacroiliitis. Still think there's some work to do, but there's possible potential in the future.
So your first report, what's the recommendation? All go to a central reader or an academician, and you guys in practice need to go back to school? What's the point of the research?
Yeah, that's really interesting. I think I mean there are some discrepancies between when you compare it to the academic versus the community. I don't think it's something that that the community is that it's slower, but I think that there are some gaps, and I think there's always room for education, reiteration, going over the modified New York criteria, seeing what I think also like looking to see where's that discrepancy, which cases is there disagreement on, and why is there disagreement too, and maybe that gap can be then used to kind of improve the agreement and maybe more uniformity in terms of detecting sacroiliitis on imaging. I don't think it's something that we should delegate it strictly to the central versus the academics. I think there just can be some discrepancies that are open for discussion, and that we should look and see what the discrepancies are and look for and kind of further look into that and see what we can fix from there.
I think eventually this is all going to be replaced.
By AI?
I think they're getting better. They've been like, if you start, I mean, I've just been paying attention to some of the radiology meetings, and you'd be surprised on what they can achieve. The dermatology meetings are already talking about it. There's some things that can be totally replaceable, but because sacroiliitis for us is mostly like a screening thing. We are still not 100% relying on that. We'll still look at the clinical picture. So an AI algorithm will do enough, I think, in the next 5-10 years. I don't know.
So Antoni, you're a SPA guy. What do you think of this trend?
I think this will be more for cases where there is probably no agreement between the radiologists where you might go to a central place for confirmation. I think in routine practice, we will still be using our local radiologists. There might be cases where the machine learning can be used for more routine scan screening patients, but we will still need some validation with the human eye. But certainly we're doing it in trials now where we send away scans just to get validation and standardization, but not for every patient.
You know, some of you work in institutions where you've got a good musculoskeletal radiologist. You really do, and that's a great thing. I've worked in those places. I've worked in places where I had a radiology department, and the request would come in from the arthritis clinic, and the radiology report would be arthritis present. And I would be, and I'm paying for this? In this situation, AI would be far preferable. But I really want, you know, an expert. And who's going to be my expert if it's not me? Janet, what would your recommendation be? Do you want to replace man with machine?
Yes and no. So again, you don't want it overcalled and you don't want it undercalled. So I think if you have a high index of suspicion, even if you have a negative MRI, you're going to start looking elsewhere, HLA-B27 positive and uveitis and a stiff lower back. So I think sometimes yes and sometimes no, but I think we have to realize that if you teach machine learning AI really well, it will on certain things say yes or no pretty easily. But I still think takes us about a minute and a half to look with our eyes as well. So I think we should look.
Yeah. All right, let's move on. Cassy, do you have an interesting one from today?
I sure do. So I focused a lot on Dr. Alexis Ogdi's work. She had 2 abstracts today that were just so interesting. And really the big focus is on mismanagement of seronegative spondy diseases. So mostly ankylosing spondylitis and psoriatic arthritis. The first abstract is 0402. And this had over 1,000 patients, with the majority being psoriatic arthritis and the minority being ankylosing spondylitis. And more than 20% of the patients reported using opioids. And opioid users had more comorbidities. They were seeing the doctor more frequently. They had worse disease activity and a higher prevalence of smoking. So everybody on this call knows that we don't treat our diseases with opioids. They don't fix the problem, they mask it. And if we're masking pain, potentially we're not able to treat to target using the biologics and the other medications that we have. And I feel like this field is really moving forward. We have so many new biologics that were discussed at this meeting, and we have so many options for these patients. And so we need to make sure that we are reassessing their pain and not relying on pain control as the main outcome for these patients. We need to make sure their disease is actually controlled. And on that note, there was another abstract that she reported here. It's 0078. And this is looking at primary care doctors versus rheumatologists managing seronegative spondyloarthritis. Rheumatologists were more likely to use biologics, whereas primary care doctors were more likely to prescribe pain medication, both opioid and non-opioid. And so again, I think everybody here knows that if somebody has one of these diseases, a rheumatologist needs to be involved in the care. And we probably need to be seeing them more frequently after they're first diagnosed in order to get rapid control and prevent reliance on pain medications in the future.
This is a big problem. You know, it's sort of out of your hands. And although rheumatologists use opioids in these patients too. Did she offer, or the discussion offer any other reasons for appropriate narcotic use in this population?
So, you know, I think when there's sequelae of disease, so when the disease is no longer reversible and our biologics and our DMARDs are not going to change the outcome, that then maybe non-opioid pain control is certainly an option. It is always an option throughout the course of disease. And then also using supportive care, things like physical therapy and things like yoga and stretching, trying to educate patients on ways to avoid a reliance on opioid and non-opioid pain control. But it's a multi-disciplinary approach. So you have a physical therapist, occupational therapy, maybe even a mental health provider to help to cope with chronic pain. So there isn't a one-all solution, but I think as providers, we need to be aware that this is a problem that we may not be able to control completely, but we can play a role in hopefully minimizing some of this reliance on opioids.
Robert, you've seen these reports in the last few years. what do you take away from all these together that
Yeah,
would be helpful to people?
Thanks for that. I really wanted to comment on that one, the opioid study. I saw the exact same one. Actually, I think to me, what the most pressing thing from that study was actually the opioid users ended up having to pay more for medical costs and drugs. So I think that actually tells us a lot. Are these people who are using opioids, do they even have the same insurance coverage, if any insurance coverage? Why are they paying more for drugs? If I'm a patient there and I'm paying hundreds or thousands of dollars for something that another patient pays $5 a copay for, I can see how I could, not use that drug or not want to spend my monthly income on that drug and take the easy fix. So I think, yes, we all know opioids don't work. We know there's sometimes a stigma with these patients, and we should not propagate this. But I think that discussion, obviously, with why the healthcare costs and the drug costs are so much more, that's like another hour a day discussion into the healthcare overall. But that I thought was very, very interesting.
Yeah. All right, let's move on. Antoni, do you have an interesting one?
Yes, I really enjoyed the plenary session today, in particular the study on remibrutinib, which is Bruton tyrosine kinase inhibitor in Sjogren's disease. For a long time, we've been looking for a specific disease-modifying therapy in Sjogren's, and so this is looks quite promising. It's a phase 2 placebo-controlled trial where they had 100 patients in the active arm and about 24 in the placebo arm. At the end of 24 weeks, there was improvement in the Sjogren's scores, the SDI score, and also the ciliary flow, and also a drop in the immunoglobulins. And overall, it looked like it was quite well tolerated with no major significant side effects. I think obviously more studies will need to be done in a larger cohort to prove this, but it does look promising.
So it's me against the rest of you, okay? Because usually when I bring this up, I get in a lot of trouble. Sjogren's syndrome is 70-80% fibromyalgia and dry mouth, okay? And the Sjogren's syndrome is riddled with all failed trials. DMARDs fail, biologics fail. Things tend to look good in phase 2. This is a phase 2 trial. We saw a phase 2 trial last year that looked good, and then they crash and burn in phase 3. So was there something about this trial that gives you more hope that, and I really have a hard time understanding how a BTK inhibitor is going to actually help Sjogren's syndrome, but nonetheless, there is a biologic plausibility here if you believe there's ongoing inflammation, it drives manifestations. But was there something about either the way the design of the trial or the outcome measures that would give you more hope that it actually might work better in phase 3?
I think they had quite good stringent outcome measures here, both in terms of objective measurements, immunoglobulins, also using the ciliary flow and the SDI score. I think the numbers for phase 2 study was fairly good. And also, I think there might be some biological plausibility with B-cell activation through BTK. Like I say, I think the test would be when we get to phase 3 and bigger numbers.
Any other gut reactions to the plenary session?
Yeah, so in terms of the Sjogren's study, so one of the unique selling point as well was in terms of the patients' diversity. So there were only about 65% were white, and the others, like they got Hispanic and so forth. So I think that's quite one of the unique selling point. But the negative side of it is the patient-reported outcomes, all of them. So the ESPRI, the fatigue, the pain. None of them actually improve in both arms. So I think that may be quite tricky of that. So I think if they want to potentially use like a composite, measure when they do a phase 3, I think it may be a bit difficult if you want to compare the clinical and the patient reporting together. So I think it's up in the air. I think I agree with you, Jackson.
Janet, you had a comment?
Yes, I was just going to say that I think if you want to find change, you want people with lots of serology, Rho and Law or SSA, SSB, You want probably a high ESR, but I think what would be most informative is early disease, because once your glands are scarred, they're not coming back. So you need lymphocytic infiltration in the glands, probably lower disease duration. And of course, we all do know that it's although fibro is a common comorbidity, to be dry eyes, mouth, achy, etc., inflammatory arthritis, vasculitis. It's not a fun disease to have by any means. So we need help.
Yeah, I certainly would love to see something, because I made the horrible mistake once as a fellow of picking up our visiting professor, who was famous for Sjogren's syndrome, Dr. Norman Talal. And, and I was a fairly good fellow, I thought, and I'm driving him to his hotel, and he says, so what do you do? What are you interested in? And what's the most common autoimmune disorder worldwide? I didn't know I was going to get quizzed on my taxiing duties. And of course, I made the mistake of not saying Sjogren's syndrome, which is what he's worldwide famous for, if you can include, primary and secondary. I'm still scarred over the whole thing. So anyway, you're up.
Yep. So I'm going to talk about COVID still. So I'm just going to talk about Evusheld. So the early experience from Dr. Cassandra Calabrese and team. So the abstract number is 0799. So as we all know, rituximab has been getting a lot of bad press in terms of clinical outcomes during the pandemic because of its effects on humoral immunity. Therefore, we need some more extra mitigation strategy, for these vulnerables in a patient. So Evusheld has been licensed in America since late 2021. So they've started using this in Cleveland from January, and the period of observation was for 4 months, January to May. So they studied in people with immune-mediated inflammatory disease on B-cell depletion therapy. Just over half of them had a diagnosis of rheumatic disease, and others like neurology and so forth. So they found that so they gave Evusheld in 417 patients. That 4 months period observation, there were only 3% risk of the development of breakthrough infection, which were only 13 patients of it. And of these 13 patients, there was only one that required hospitalization. So this early experience is quite encouraging and promising for Evusheld. However, there's quite a few limitations. It's because of variants change. And then, how long did the Evusheld last? I think we probably need like 6 monthly. So I think we need more data. But then again, if we need more data, then the variants change again. So I think it's just never ending. But, the bottom of line is, although we're talking about that, vaccination is still, key, for our patients, really.
So question, the background therapy in these 400 patients, these are not rituximab patients, were they?
So they were all B-cell depleting therapy. So they've not specified, some of them rituximab, some of them could have got either, obinutuzumab or so forth there.
I've run into some rheumatologists in my travels who are using Evusheld in our autoimmune patients who are taking immunosuppressives. And I'm not talking about rituximab. I'm talking about being on mycophenolate or azathioprine or even an IL-6 inhibitor. And I look at them and I say, well, that's just a little crazy, if you ask me. Does anybody think that we should be using Evusheld in our patients who are on biologics or immunosuppressives?
Only rituximab due to the worst data, although MMF had data that was at risk. I think rituximab, especially repeat users for 12 years kind of people, their B cells are down. A lot of times they're older. So we're using it for rituximab only in our patients, no one else.
Yeah, I think it makes sense there. That's a no-brainer. And I think it makes sense in people who are really sick and immunosuppressed. Our patients who are at greatest risk are autoimmune patients who have very active disease, maybe on high-dose steroids, maybe on multiple immunosuppressives. That might be a good move, honestly. But you have to make the judgment call about how immunosuppressed they are. So this clearly is a gigantic advantage, and there is a large population who are not being treated as Hughes describes what they did at Cleveland Clinic. and it should be done because as they showed, it worked. Anybody have any trouble getting Evusheld for their patients?
Yeah, we are in the UK. Yeah, so it's just not getting there. The Evusheld been approved by EMA since March this year, but we couldn't get it because the government said there's not enough data. So the initial trial that shows 71% reduction in breakthrough infection was conducted in the Delta phase, not the Omicron phase. Yeah, and because of that, so I think a lot of people been railing about it. A lot of patient groups and everything been railing, and we're still not getting any joy of it.
Right. Okay, that's interesting. Sheila, what's going on in where today at your view of the meeting?
Okay, so I've decided to talk about cardiovascular complications in lupus, and I've chosen abstract 1596, where they looked into the role of coronary calcium screening in lupus patients who appear to have a low cardiovascular risk. So usually the risk calculators like the ASVD that we can use to assess if a patient has an indication for statin risk. So they usually do not incorporate non-traditional risk factors that may underestimate the risk for SLE. And we know that in lupus, patients are at high risk for cardiovascular disease. So what they did here was this was actually a post hoc analysis of a prior cohort study. So there were female patients were recruited, and age match controls were recruited. And so they looked in, sorry, I forgot to mention. So they consider that aside from using the ASVD risk calculator, the cardiac CT could be quantification of coronary artery calcifications might play an additional role in, or an adjunctive role in aiding stratification for cardiovascular disease. And so they looked into these patients where those with ASVD, they calculated the ASVD risk, and then what the results show is that among the SLE patients who had low CVD risk, according to the calculator, 34 out of 122, or that's 28% of the subjects, had abnormal coronary artery calcium scores compared to the healthy age match population. And only 4 or 12% of the low ASCVD risk who had abnormal CAC scores were on statins. So basically what the study here is saying is that, okay, we do not need to do CT scans on all patients with lupus or those with low ASCVD risk, but the results show that SLE patients were significantly more likely to have abnormal CACs compared with controls, particularly those patients who had advanced age, had longer disease activity, had higher total cholesterol and higher LDL results compared to those with normal CAC. So initially I was thinking, so do we need to do CT on all these patients? But no, it's more actually of guiding us as to whether, for example, we need to consider rescreening or probably regular screening of our lupus patients, particularly those who are higher age or those with longer disease activity. Maybe we need to reassess their cardiovascular risk, especially if they're not really on statins, and maybe the indications will be there if we do the screening on these subset of patients.
So Sheila, what was the age of this group of lupus patients?
Okay, so there were the average was about 39 39 years of age.
That seems like a reasonable age for a lot of lupus cohorts. It's not the lupus patient population I treat at the county hospital, who are all young minorities, and so I can't imagine it's being very appropriate in those people. But this boils down to the issue of what's the real predictive value of coronary calcium scores, and moving forward. Do any of you advocate for this in any of your patients right now?
In that age group, no. I mean, you've got the risk factors that you're going to look at and should treat. I mean, the cardiologists like it in older people where you're wondering, is there coronary artery disease or not? But I wouldn't routinely do it in a 39-year-old lupus patient, even if they were 10 years on steroids. I'd look at the metabolic syndrome stuff first.
Exactly. That's what I was going to say, is that just like we look for fatty liver disease, maybe in psoriatic arthritis patients, we always need to have an open mind about these patients having almost advanced metabolic issues beyond their age. So checking a lipid profile, checking an A1C, talking about weight and diet and hypertension, I think that needs to become a part of our healthcare maintenance, just like cancer screenings and vaccinations and smoking, all that kind of stuff. I think this study is a great example that we need to have this on our radar and stratify these patients, knowing that the traditional scoring systems don't take our diseases into consideration.
Yeah, I have some concerns about it, because I've heard stories where the number was 0 and they're dead a month later, and the numbers where it was a few thousand and they've lived 10 years. So and it's sort of like the academic rheumatologists say that they won't do it. The community rheumatologists are fishing for new cath candidates, and so they use this as a justification. But I think maybe the great thing here is that it was subjected to study here, and this can maybe help inform how you're going to approach your lupus population. Let's move on with Janet Pope.
Great. So Kevin Dean had a busy day today. So he was doing the Stop RA trial as well as the RA debate. So I want to talk about two trials very briefly. So 1604 was 20-site RCT of CCP3 positive people with a fairly high positivity, followed for 3 years or more, a median of 3 years, randomized to hydroxychloroquine or placebo to try to stop RA, which is the name of the study. And wouldn't it be great if we found that hydroxychloroquine worked? The rate of getting RA in these patients, some had symptoms, some didn't, but they couldn't have overt synovitis. So you couldn't be already having inflammatory arthritis. So over the few years of follow-up, about 1 in 3 developed RA, which I think is actually a little bit high, but it's on target with some other studies. So it was a good enriched population, but the two graphs were identical. And I just want to compare it that yesterday, a further follow-up of the ARIA or ARIA trial, which is abatacept versus placebo in these pre-RA patients, strongly ACPA positive. They could have arthralgias, but they couldn't have overt synovitis. And they did very interesting trial design on the area that was abstract 530. They looked at MRIs, that's what they reported, but the bottom line was these at-risk patients were randomized to abatacept for 6 months or placebo, and then followed another 12 months on no treatment, so 18 months, and they're still finding less RA in the group, although some of the benefit is being attenuated as you're not on drug for a long time, but less RA still at 12 months after stopping your abatacept, so 18-month trial, than placebo. And the MRI was showing that as well, that less subclinical synovitis. So abatacept, fairly expensive. You don't know in whom you'd use it in pre-RA, and hydroxychloroquine fairly inexpensive, and unfortunately was a wash. So I think we'll keep an eye on this space.
So let me confuse it a little bit further. Tomorrow they're going to present the Treat Earlier trial, which was presented at EULAR, which is already in press. It's a methotrexate intervention in at-risk individuals that did not meet its endpoint in preventing RA or swollen joints. But if you look at individual components like pain and work and MR and stiffness, the two treatment arms, placebo and methotrexate, never met. It looks like it showed some individual symptom or single parameter benefits. And as we discussed at ULAR, a negative trial is being viewed positively by a bunch of people. So Janet, I have mixed results with methotrexate. I've got a negative trial, or maybe that's negative results with methotrexate. I got a negative trial hydroxychloroquine, but abatacept seems to look good. Are rheumatologists any smarter going forward on this?
Yes and no. I mean, the closer you are to RA, the more likely you'll get RA. So the old methotrexate study, I think it was about 15 milligrams, was randomizing people that didn't meet ACR criteria, but in my mind, they actually had RA. They had swollen joints, etc., but meeting the 2010 criteria for RA. Methotrexate delay for 1 year of treatment delayed the onset of an RA classification, and when you stopped it, the people regressed. So we got positive and negative data from methotrexate, but I think that we have to, it's a grab bag. It's like pre-diabetes. What does that mean, right? It's the same idea, pre-RA or RA at risk. Some of these people actually are inflammatory arthritis that we either don't detect or we just don't label yet. So more to come, I think.
So I want to really strongly underscore what she just said, which is different than what Kevin Dean says and what I've been saying. Your risk of RA ratchets up from environmental risk to an autoimmune state, to then you get, you're a smoker and you're double positive, and the more you add on, you ratchet up your way to RA. But it really is what Janet said. The closer you are to RA, the more comfortable you should be in using something. The further away you are, it's still going to be symptom management. I think that's the smart way to really manage the situation. And 10 years of research, and Kevin Dean has, spent millions of dollars and lost all kinds of sleep over it, and Janet figured it out in 2 minutes. Brilliant. Robert, you're going to end the show.
All right. So every conference, I try to scat out some gut microbiome abstracts because they interest me very much. And I'll talk about why in a second. So this is actually in the world of JIA. It's abstract 0868, but still pertains to us in Spondy. They looked at, it's a small study, but they looked at potential alterations in the intestinal flora of neonates. Now, they keep in mind, they did not actually study the gut flora itself in terms of like GWAS and such. They used factors, inferred factors that could affect or interfere with the gut microbiome, including the mode of delivery, choice of early diet, things like breast milk versus TPN versus formula, antibiotic exposure in the mother, and maternal smoking. Interestingly enough, the only factor they found that affected the development of spondyloarthritis in these babies was antibiotic exposure. And it actually increased the incidence of spondy by 6.2 times. And that further increased with the greater number of antibiotic exposures. And none of the other things that, I guess this makes sense because we understand that antibiotics can affect the gut flora. But interestingly enough, also, none of the other factors, you would think maybe early diet would affect it, not so much mode of delivery, and again, maternal smoking. And to me, why I like or try to focus on gut microbiome, because I think, one, it's a new frontier, a lot of unknown, and two, patients ask us about it. I think the reason why, from my personal opinion, is they feel like they can control it. Gut microbiome, instead of listening to us for what we recommend as a medicine or what test to order, they can control gut microbiome. But this study shows us maybe they can't. If you're sick and you have to take an antibiotic, you have to take it. You can't not take it if you're sick as a mother. But maybe there's changes we can make. Maybe we don't treat every mother with a sneeze and a cough with a Z-Pak. Maybe if they are sick and they do require antibiotics, do we think about probiotics? But I thought this was a very interesting approach on neonatal gut microbiome.
The question is antibiotic use a measure? What is it a measure of? More doctor visits, better medical care, earlier diagnosis of cataracts, and also JIA, or was it an altered, immune system and maybe an altered microbiome? The question, and so this issue of antibiotic prescribing as a prelude to our diseases has been bantied about for over a decade without a lot of resolution. And I think it still is, I wish someone would take it apart, by going really deep on this. But right now, it's hard to blame the antibiotics for disease, thinking that they altered the microbiome. Does anybody have a different view of this?
Well, I think what you're getting at is it really could be infection, or it could be the host already has issues. However, I think good clinical practice is, if you don't need antibiotics, no kidding, don't use them. And that little babe could be at risk. And they even have studies saying a vag delivery, because it probably doesn't get antibiotics, versus a C-section, you actually change the microbiome of that kid from day one. So maybe there's something you have to go through the vag, like the birth canal, or maybe it's you get your on-call antibiotics for a C-section. I don't know.
Okay. All right, folks. Great session. Thank you all for all the work you do in covering the meeting, and tune in tomorrow for day 3 recap from the ACR Room Now faculty. Good night, everyone.